Informatics and Implementation Science Learning Series seminar. As a quick sort of administrative reminder, there are two more such seminars scheduled for the balance of the year in December. And if you haven't yet signed up for the listserv, then please do so. We've been doing a lot of the sort of announcement of these through direct emails, but that'll sort of start to cease to save everybody's inbox. And so if you are interested in keeping up with the seminar series as it progresses through the year, then please make sure that you sign up. My name is Neil Sarkar. For those of you who don't know me or weren't here the last time, I'm the President and Chief Executive Officer for the Rhode Island Quality Institute, which operates our state's health information exchange. And this seminar series is co-sponsored by us at RIQI, the Brown Center for Biomedical Informatics, and Brown's Department of Psychiatry and Human Behavior Implementation Science Corps. We're also grateful to Advanced CTR, the statewide IDEA CTR program that helps support a lot of these collaborative initiatives across our state. Today, I'm delighted to welcome Professor Frazier from Brown, as well as Stephen Wanye from Intellisoft Consulting. As we all know, COVID-19 has brought new terms to our lexicons here in the United States. Words like contact tracing, case positive, case negative were not part of the parlance for the day-to-day American. These are things that are new to us, but have not been but are not new in the global realm. And the support for electronic health, using electronic health records, laboratory tests, and the like. We here in the United States, we've been piecing together our public health infrastructure as best we can. But there's a lot to learn from electronic health record systems, not just here in the United States. And so Professor Frazier and Mr. Wanye will share with us some of their experiences and insights from a global perspective. And so with that, I'll pass it over to Professor Frazier.
Thank you, Neil, for that introduction. I'll also introduce Stephen here at this point, and then he will join part of the way through and talk about the work he's been doing in Kenya. So Stephen is a software developer. He did his BS degree in computer science from the University of Nairobi and has a diploma in health informatics from the University of Washington and a master's degree in software engineering from the University of Liverpool in the UK. He's also playing a key role in many informatics organizations in Africa. He's a member of the Safaricom Health Advisory Board in Nairobi. That's a mobile phone company. He is a board member of OpenMRS Inc., so the organization that leads OpenMRS. And he's also a board member and executive general secretary of the Kenya Health Informatics Association, and also HELINA, which is the Pan-African Health Informatics Association. And Stephen is currently a candidate for PhD at the University of Nairobi. So I'm going to talk a bit about the work that I've been doing for many years on OpenMRS with many collaborators around the world, and also the way that that work has led to new initiatives around disease surveillance and management of disease outbreaks, and of course, in particular, the current crisis with COVID-19. I'm just going to get my slides up. Okay. Oh, that's not right. Excuse me. Slight pause there. I'm not sure why it's not showing the right one. Okay, that's my slides, not Stephen's. All right. So, sorry for that pause there. So I'm going to talk a bit about some of the key epidemic and endemic infectious disease questions that Neil alluded to in many low middle income countries, and this point that the ideas about managing infectious diseases and outbreaks and pandemics and so on is really a day-to-day problem in many countries. And so the COVID is not a really new thing, but yet another of these problems that has come along in the wake of many other problems. And we'll talk a bit about the...
Hamish, I'm going to interrupt you for just a moment. We're seeing your
using the double.
presenter
Okay.
view. Click the swap displays. Yeah.
Yeah. Okay. So it's,
Sorry.
for some reason it does it both ways of my screen when I'm doing Zoom. I don't know why. It doesn't change one to the other. Thank you. And then we'll talk about electronic health records in low and middle income countries, and particularly the Open MRS system, and how that fits in with a larger digital health ecosystem, which has been used to support a number of different disease management programs around the world, and including epidemic response, and how that fits in with the work with SARS-CoV-2. So moving forward, one of the challenges that we knew around the world are there are so many infectious diseases that have emerged recently. And this is a list in 2019 of global health emergencies that WHO provides on their website. And so throughout the year, they have warnings and alerts about different disease outbreaks. And so this was just the year 2019. You can see there are many problems, some of them well-established, long-standing problems like yellow fever, but also cases, MERS, whether there are outbreaks of new or established diseases. Each country has to then respond to those. And usually there are district, national, and then international approaches to identifying these diseases and then addressing them, with reporting going through WHO typically. So countries are familiar with these problems, and they have to develop systems that can let them manage these different problems. And so we see major outbreaks and problems over the years that many organizations have worked with from the US and around the world. Of course, HIV, tuberculosis, major problems of drug-resistant tuberculosis, malaria, and then of course the Ebola outbreak in West Africa in 2014, 2015. But also very common major causes of death in children, such as pneumonia and diarrheal disease, and a range of neglected tropical diseases. And so for each of these, there are processes for case finding and surveillance, tools for case management and clinical care, and then also issues around supply chain management, to developing and supporting new therapeutics and vaccines, and of course doing clinical trials to identify more effective therapies. And then training and decision support, so that community healthcare workers and nurses and other healthcare workers can actually provide high quality care, often in remote areas, and sometimes with new diseases like COVID or Ebola. So this SARS-CoV-2 pandemic, obviously a major worldwide crisis. And immediately when this struck, there was great concern about what would happen in low and middle income countries due to the vulnerabilities these countries have to health outbreaks, such as low income, poor infrastructure, generally fragile health systems, limited number of healthcare workers, for example, and the fact they're already dealing with many epidemic diseases. Although interestingly, that last point may in fact be some ways a strength rather than a weakness. So luckily at the moment, the initial impact seems to be less severe in some low income settings, particularly in Africa and in Haiti, which is another country where I work. And that has led to less mortality and maybe less cases, but it has still caused a lot of economic disruption and effects on the general healthcare system, such as the level of general vaccination rates for children and other forms of preventative disease, such as management of HIV and TB. But in so many countries, health information systems have really become the heart of monitoring and management of pandemics and also day-to-day care. This just gives an example from WHO today, looking at the mortality rates for COVID-19. And you can see that although Africa certainly has its share of cases, a lot of the more vulnerable areas in Central and Sub-Saharan Africa don't have as high rates as other parts of the world at the moment. These are some examples of the cases looking at the countries I've been particularly interested in. So Kenya, Haiti, Nepal, and also Rwanda, where I work. And you can see that if you look at the cases per million here, that they're relatively low compared to countries like the US, UK, or Germany. You do, however, see that the death rates are relatively similar in Kenya and Haiti, even though they have different rates of disease recorded. So Haiti is probably doing less effective testing. And of course, you have to look at the size of the country and the logistics of getting to different parts of the country. Nepal has a higher case rate and also a high mortality rate. Rwanda is very low. And knowing Rwanda fairly well, and it's a fairly compact country with a very well-run health system, these are probably accurate numbers. So there's some interesting questions there. However, when you look at the cases, this is the curve for Kenya. So it started later in many ways than European countries and many parts of the US, such as the Northeast. Peak in the summer, but then also a fairly large peak is developing at the moment as well. And so when we look at the overall burden in Kenya, Africa accounts for about 17% of the world's population, but only about 3.5% of the reported COVID-19 deaths at the moment. Looking at September 30th numbers, so that was UK had just under 42,000 deaths, and Kenya was only about 691 then. If you compare the populations, and then also you look at the age stratification for these different countries, the average age in Kenya is, of course, much lower, half that of the UK. And when you look at the increased risk for elderly patients, it turns out that just on that basis, you'd probably expect a death rate in Kenya of around about 5,000 patients, rather than sort of 35,000 or so, which would be the equivalent for the size of country affected by the UK. And so that means that the numbers are going to be lower probably. But then if you look at, say, the comparison with Germany, which obviously did much better than many countries in controlling the outbreak, then Kenya might actually be around about 1,000 to 1,500 deaths at that point. So, there are interesting questions about whether these countries are a little bit more protected, but then also there are lots of questions about case detection. So countries that are less effective, and I think Haiti is probably one example of that. But Kenya maybe not, and Stephen will talk about that. The timing of the outbreak, it started later in Africa. Hotter and more humid climates, genetic differences, and use of BCG vaccine are other factors that may be relevant in this context. So pivoting a little bit to the information system responses to these problems. So global health or informatics, or global e-health, is a field that really combines a number of different specialties. So obviously health information systems are built on technology, but they also take into account many of the challenges and the processes of healthcare. And then also in this context, development. And as people who worked in any of these areas know, each of these fields has their own languages, their own ideas and approaches. So global health informatics really has to think through all of these different pieces, and then also to incorporate other factors such as evaluation approaches, anthropology, logistics and supply chain issues, and so on. And in context of healthcare, particularly improving quality of care, there are many ways in which information systems can be helpful. And of course, in this context, particularly measuring the burden of disease and looking at disease surveillance approaches are key. And also monitoring processes of care and outcomes, communicating life-saving information, so adverse drug reactions, lab results, in the context of maternal child health, risk factors for maternal and newborn care. And then looking at how we can improve quality of care, particularly when you're dealing with more complex diseases like HIV or drug-resistant TB or diabetes. Can those alerts and reminders and information for improving training of staff allow task shifting from more experienced physicians to nurses, or also to community healthcare workers? And so there are a lot of different ways in which these systems can be effective. This is just an example of some early work we did in Haiti, developing an original HIV web-based medical record system. And this led to a lot of ideas about how health information systems could be helpful in managing other diseases. And this led to some work to develop a much more general purpose approach to managing health information. And so many of you have heard me talk about this, but back in 2004, the challenge we were facing were that we were looking to work in multiple countries with many different languages, dealing with multiple diseases, often limited infrastructure and technical expertise, and kind of an uncertain funding situation where if you did develop a successful system, you needed to have a way of maintaining that system and supporting it long term. And in addition to this, we had some really key goals around sharing the best practices, designs, code, and also metadata of systems, so that healthcare workers and organizations and ministries of health in different countries would not be starting from scratch, but would be able to learn from the best practices and also learn from the mistakes of other organizations. And this meant we could do things like supporting more complex and strategic capabilities, particularly around interoperability and standards for data management, and building communities around innovation. So building strong focus in innovation so that countries like Kenya and Rwanda and Haiti could actually build their own systems and to develop their own capabilities. And as Stephen will, I'm sure, tell you, Kenya has really taken that idea and run with it in a fantastic way. So this led to OpenMRS, this open source modular EHR platform. And this uses a concept dictionary to manage the data. And of course, it's designed to be secure and to manage data, the patient logins and so the user logins very effectively. And we work very hard to ensure that these systems are secure, and had, for example, an audit of the system used in Uganda last year, funded by the CDC, to make sure that the system was working effectively in the communities. The modular design has really helped to make it easier to adapt in different countries. And it's supported by a core of paid programmers in many different organizations, so that there's day-to-day people who really focus on the system. Organizations, particularly like the Reagan Street Institute in Indiana, AMPATH in Kenya, increasingly a number of organizations in Kenya that Stephen will talk about. Also, we do some work from Brown University, and Ian Batcher, part of our team here, has been taking a lead role in some of the work this year. The system is in clinical use in 44 countries at the moment. It's probably a lot higher than that, but I was able to confirm those 44 countries this spring, and about 5,500 health facilities. Here's an example of some of the distributions of OpenMRS. So the upper one is called the reference application. It's the main track of OpenMRS at the moment, originally developed for Haiti and for the Mirabali Hospital there. And then Kenya EMR, which was developed around about the same time. It's very similar, but with slight differences in the user interface and organization. And that's had a lead role in Kenya for about a decade now. And as I said, the way we organize data management in OpenMRS means that only a handful of data items, basically demographic data, is collected in the database without having a concept, so that you can actually modify the system to collect a whole range of different kinds of data, whether it be more clinically related data, socioeconomic screening data, but also information about patients' homes or the transport they use to get to hospital and things like that. And this work has been led by Andy Cantor, who's a founder of IMO and also works at Columbia University. So Andy has done some important work adapting the concept dictionary to various different diseases. So we did very important work around the Ebola outbreak. And then this spring worked to improve the mappings for COVID-19. So you can see that the OpenMRS comes with some very sophisticated mappings. So it covers more than 50,000 concepts in SNOMED CT, over 40,000 in ICD-10, and also RxNorm and LOINC, 3BT and other systems. And there's also a number of languages supported, particularly Spanish and Dutch, interestingly, which surprised me. But we also have concepts in Haitian Creole and in many other countries and languages. So taking an example from the concept dictionary and with COVID, so one of the concepts that Andy created in the system is acute respiratory distress syndrome, ARDS, due to severe acute respiratory syndrome coronavirus 2, short name, ARDS due to SARS-CoV-2. And that was obviously mapped to its own unique concept ID number, and it also has a UUID. And then that has been mapped to different coding systems. And you can see there's a narrow than link here for ICD-10 WHO and ICD-10 second version, whereas there's a same as link to ICD-11 and SNOMED CT. And so this has allowed us to provide a core concept dictionary for different organizations using the system. And this has been incorporated in some of the profiles for FHIR used in the US as well. And this is just an example of the sort of structure of the modular architecture. And you can see how the system is built with a very basic system with the database, user management, and standard APIs. And then on top of that, almost all the functionality comes in the form of these different modules, some of which were developed by the core team and validated against different releases of the system, but many are independently developed. So unlike most EHR systems you'd see, even if they have some of a modular structure, the components can be developed by independent developers and plugged together And the typical system, such as the one we used in Haiti, would have somewhere between 40 and 50 modules, all put together to form the system. And then the user interface layer sits on top of that. And there are some newer versions of that. So BAMNI and the reference application are slightly different. And there's a new version coming out that will improve on that. And OpenMRS is also an early pioneer of Smart on Fire. So we can actually support smart modules as well, so that you could develop them with OpenMRS, but also use them on other more commercial EHRs. And so I don't want to take too much time, so Andy, this time for Stephen, but these are just examples of some of the sites around the world that use OpenMRS. You know, the problem with an open source system is that you don't control the source code. So there are many countries and organizations using the system in some way or other that don't necessarily report that. So I said 44 countries means actual clinical use on an ongoing basis, but there are probably a number of others. So when we start to think about the broader digital ecosystem around OpenMRS, this is an example of an EHR system like OpenMRS used in a clinical setting or a hospital, for example. And then it can talk to laboratory systems. So this is the OpenLS open source lab information system. And so now there's a new version that uses HL7 Fire rather than the older version of HL7. We also can talk to pharmacy systems, radiology packs, and DCM4Chi is used in a number of sites using DICOM standard, of course. And then you have this national reporting system, DHIS2, and a WHO supported standard called DXF2, which allows you to export aggregate data. So for example, a report on, say, 3 monthly numbers of HIV patients or TB patients, that report can then be converted into an XML format that is taken up directly by the national reporting system. And then here we have important work with mobile health systems. So ComCare is an example of a system that was developed for community healthcare workers originally in Rwanda and other countries. It's now used in dozens of countries, developed by Demagi in Boston, actually. And as of the outbreak of the SARS-CoV-2 pandemic, it's been used in Massachusetts and California and other parts of the US and around the world to help contact tracing and case surveillance. And so just a little shout out to the work that Ian's been doing with FHIR. So we had an early implementation of FHIR back in 2015. And then this year, the development of this new module was architected by Ian and colleagues at the University of Washington and AMPATH in Kenya. And so this system built on the Happy Plains server now translates the data from OpenMRS database to FHIR resource representations. And we can use this directly for managing the connection with the lab systems, but also it's becoming a resource that can be used to talk to new user interface components in what's called the Micro Frontends project. And also we're looking at how it can be used for international patient summary implementation. And then another important area here is developing updated ETL processes to extract data from an OpenMRS and transmit that to standard reporting systems and analysis systems, and that includes I2B2 and Odyssey. And this is just a quick example of the configuration of the OpenLS lab system in Haiti and eSante Plus, which is an OpenMRS-based new EHR for just going to be rolled out to about 120 sites in Haiti. And this is the setup with the Happy server. I said that's a lot of Ian's work there. So when we put these pieces together, there are a number of other organizations, of course, building systems. And these open source systems have increasingly become resources that are shared across different organizations, and through interoperability and APIs can be plugged together to build much more effective tools. So here I've highlighted in red OpenMRS and OpenLS, so the two flavors, BAMNI and OpenMRS. OpenSRP is another open source simple EHR system for the Smart Registers project, and that also talks to OpenMRS in the back end. And then we have tools for collecting data in the community, such as ODK and ComCare and Community Health Toolkit. These are mobile health tools. SORMAS, which is a really effective disease surveillance system developed in Germany and now being used more widely. And then you see DHIS2, the Open LMIS logistics management system, the Open Concept Lab that Andy Cantor is leading, training and learning systems like OpenDeliver. And each of these can be put together to build these more sophisticated arrangements. DHIS2 is a very important system, so I'll just briefly mention that. It's been developed over the last 20 something years, originally as an access database system in South Africa. It's now used in over 80 countries as a web-based tool. And over the last 5 years or so, it's moved to a much more modular approach, building on the open source backend, similar to the model for OpenMRS. And you can also take direct uploads from a number of systems and some mobile health tools as well as OpenMRS. So just a brief switch here to talk a bit more about the disease surveillance side of things. This is the project that we did back in 2015, the Ebola outbreak in Kerry Town Ebola Treatment Center in Sierra Leone. And the challenge here was that the staff were trying to work in the hot zone with the infected patients, and they couldn't take any paper out to make any recordings, to order medications or anything like that. And so they needed a sterilizable, secure system that could allow them to collect data when they were wearing PPE. Really, honestly, very heavy-duty PPE in this context. And so this is using a sterilizable Android tablet. It's waterproof, so you can dunk in a bucket of bleach, and they were able to then use that. This is the staff testing it out prior to implementation. And this was used for 150 patients, 115, sorry, patients over about a 6-week, 2-month period before the outbreak fortunately went away. But it gives a lot of experience in how to develop these kind of approaches. And many of the other systems like ComCare and DHIS2 and so on did a lot of work at that time to develop very effective case finding and contact tracing tools. This is an example of the custom interface with very big buttons, very clearly designed so you can see it and use it with the gloved hands. And so we plan to make more use of this in more in ICU type of context going forward. Another approach has been to do very simple patient registration in kind of a primary care context. It's an example from an earlier project in Haiti, which built on the work of Baobab systems in Malawi. Each patient comes in, they get registered very quickly, they collect the primary diagnosis or problems. This can either be done directly on the screen, which is done in the Mirror Valley Hospital, or on a very simple form, which can be filled out into the system in the afternoon if you don't have direct access to it. And so you can do things like just showing which areas patients came from, recording various aspects about the patient's diagnoses. And so very quickly you can plot this information. The problem is not many people do this. And so this critical data, limited primary care data set or emergency data set, can be incredibly valuable at tracking infectious disease outbreaks. And so we need to do more of this and more effectively. And then finally, the general approach so far with COVID-19 has been a number of initiatives. So in addition to the work that Andy has done with the Serial Concept Dictionary, we've added lab order entry to Mirror Valley Hospital, that's with Partners in Health. The WHO case reporting form, which Ian actually led the development of. We now have the exports of data to various reporting systems. So DHIS2 and SORMAS through APIs, but with a move towards FHIR intended. And then links to mobile applications, including Medic Mobile in Kenya. And then the next stage really is to think about how we make more effective use of the data from all these OpenMRS systems. And although there are example projects doing very effective data science work with OpenMRS, including those led by Joe Hogan and School of Public Health on HIV care in Kenya, we need to do more of that. And this is an example of the test ordering in Haiti using the system at the Mirror Valley Hospital. And this is actually the hospital there. It's a large teaching hospital built after the earthquake. Currently, they've managed about 250 plus COVID-19 inpatients. Each one has a record in OpenMRS. And they are now seeing fewer patients. And there's a question as to whether Haiti may in fact have had quite a high level of disease spread through the community, and it's therefore diminishing. We don't really have the data to know that. And finally, for my piece, Napoleon EHR, which is a BAMNI version of OpenMRS, has been collecting data since April, and they have a good track of all the patients presenting with COVID-19 symptoms. Okay, so Stephen, I will hand over the share to you and let you take over. Any questions or comments meanwhile?
Thanks, Hamish. I'm just trying to share my screen here.
Okay. You're in Nairobi at the moment, Stephen?
Yes, I'm in Nairobi. Right.
I have observed, we're talking to Stephen recently on Zoom, that it's usually better than my connection to Providence from East Greenwich, but we'll cross our fingers.
All right. Great. Right. I hope everyone can see my screen. So thanks a lot, Hamish, for the introduction. So again, my name is Stephen. I'm just going to show my face for a minute here, and then I'll turn off my video just to save on my bandwidth. Hi, everyone. So I'm going to be presenting about the work we're doing in Kenya with regards to use of open source systems, and specifically OpenMRS for COVID response and management. And so my presentation for the next maybe 15 minutes will be on overview of the COVID-19 surveillance systems and how we're using KenyaMR, as Hamish mentioned, which is an OpenMRS distribution to support COVID surveillance. It's called the KenyaMR COVID tracking system. And then I'll also speak a little bit about some work that we've been doing recently for HIV cross-border surveillance, and how that work is being leveraged on to support COVID-19 cross-border surveillance. Right. Okay, so this slide here basically just shows what has been put together under the leadership of the Ministry of Health, supported by multiple partners. And basically, I think this is a typical sort of process flow for surveillance in most African countries. So in Kenya, it typically starts with case identification and notification, where there's been a bunch of systems developed, all open source systems developed to basically detect alerts, and then basically send those notifications to a central system at the Emergency Operations Center, which is it's a department under the Ministry of Health Disease Surveillance Unit. And so those alerts could either come from the traveler surveillance systems or the ports of entry, or also within the communities, which also includes health facilities as well. And so when a case that has signs and symptoms for COVID is sort of determined, then a case investigation and isolation process is triggered, where the the national response team has what they call a rapid response team that basically follows this up by investigating the alerts, and they start doing that by filling a case investigation form. Now that's been done currently in multiple systems. One of them is a COVID-19 tracking mobile application, but it's also been done in the KenyaMR COVID-19 system as well, which is the OpenMR system I mentioned. There's also a bunch of lab systems that get transmit lab orders to the national reference labs, and also receive the results and send those back to the case management systems at the facilities usually. And then if the case turns positive, then that triggers a couple of processes, mainly contact management and quarantine management. And again, in those two phases, there's a lot of use of KenyaMR, as well as a couple of mobile applications as well, which are all open source. Some of them drawn from the slide that Hamish presented of the digital public goods, but there's also one, this called Jitenge, which was being used, but the ministry has since ceased its use. Jitenge is a Swahili word for isolate yourself. It was mostly used for quarantine management and all that. And then the last step typically is, attempt to use those information from a centralized place through the strategic information unit of the Ministry of Health, where all these data streams feed into a data analytics and visualization platform. So this is just a listing of all this, systems using those 4 steps that I've mentioned. They're all listed here, and I'll provide a link to where you can check the systems out in a couple of slides downstream. This data flow diagram, it basically follows these 4 steps and attempts to show how data flows from when the alert is received to when this data is visualized at the Ministry of Health at the national level in Nairobi. So I'm sorry, this slide is not very clear, but this is very typical from, in terms of triaging data based on certain conditions. And mostly it's really just, as I mentioned earlier, just based on the outcomes of certain determinations, whether those are lab diagnostics or based on signs and symptoms, determines how that data flows and where it flows to, in terms of the electronic data systems that are supporting this process. These are links to the systems that I mentioned. They are all managed by the Ministry of Health. So please let me know if you have challenges accessing them, but they should be publicly available. Kenya EMR is at the bottom here. The ministry calls it Kenya HMIS. And this is a demo system. So, you'll probably find some fake or synthetic data in there. So just to quickly say what has been achieved, basically a lot of this work, as Hamish mentioned, it's really, we've reused a lot of the solutions developed for the HIV program, PEPFAR program. So for example, Kenya EMR, as Hamish mentioned, we developed that through University of Washington 10 years ago to support the national HIV program funded through by PEPFAR through CDC. And that's basically what we have repurposed to use in the COVID response. The other systems that I used are, for example, the community health tool, which was previously called Medic Mobile. The LMIS, it's domestically developed, but it's also open source. And there's a couple of other open source systems, for example, DHIS2 used at the national level. And then for the for data transmission, the interoperability piece, which I also speak at towards the end of my presentation, we're using OpenHIM, the Open Health Information Mediator, which is the interoperability layer within the Open Health Information Exchange reference implementation. Excuse me. So these solutions are centrally hosted by the Ministry of Health, and there's a couple of them that are working offline just because of challenges within reliable connectivity. And then there's a lot of work going on right now, particularly by the National HIV Program, to try and determine how COVID is affecting that program, especially people living with HIV. The National HIV Program has a national HIV data warehouse with tons of data, and there are a couple of people who are doing a bit of correlations and some sort of data modeling to answer some questions. So the second part of my presentation is really now focusing on Kenya EMR, CTS, COVID tracking system, which is a distribution of OpenMRS. And I'll basically just cover this in sort of like 3 phases, show how we are using Kenya EMR to create cases, report cases, and also manage contacts as well, and also interoperate and exchange data with the lab diagnostic systems. So just to mention upfront that one of the challenges we've been having, of course, is unique identification of cases. This is a solution that has been adapted so far, where we're using the national ID for the adults, and then for children, that's just appended with the birth order to identify records in the system. And for non-Kenyans, it's mostly just been the use of passports as a primary ID across the systems. Now, of course, this is not so obviously foolproof, but so far, just based on the data quality assessments done, it's proven to be generally reliable. So this is the login page for Kenya EMR, typical EMR system, and their credentials there. If you want to try this out, I'm not sure if this server is up. It's at the Ministry of Health. And once you log in, the ministry wanted to just have some very, very basic dashboards, just these bar graphs, just showing, for example, the reporting on that day that you're running the reports, or you're logging in, and once you do that, sorry, something got lost. Okay, once you do that, these are some of the things that you'd also see based on on how you log into the system. There's a summary of the registration and travel history, case investigation. You probably see a couple of records here, and then if this person was ever quarantined, you also see details about their quarantine experience and the encounters in the, especially it's mostly institutional quarantine. And then there's been the system has also been collecting some comorbidity data, especially for chronic diseases, and particularly there's been an interest in collecting HIV-related information for these persons as well. And then on the right here, there's also been some data around lab order management. KenyaMR is integrated with the lab management system, and so, but it also allows for manual entry of lab results. But for the most part, it's been working fairly well, receiving data electronically from the lab system. Registration is typical. There's a minimum data required for completing a registration of a case, which is defined by the Ministry of Health and also by the disease surveillance team at the Ministry of Health. So basic demographic information, as you'd expect. And then you can't see clearly at the bottom, but there's a section here that requires extensive data on physical address and also, for example, mobile phone numbers for contact tracing and for follow-up as well. And then just in terms of, excuse me, just in terms of, let's see what else is new here. Other functionality in terms of, for example, when you're reporting a COVID case, this has also been defined by the ministry. There's a set of guidelines that has been followed and defined essential minimum data that that every reported COVID case needs to contain. Again, this has all been repurposed from the same features used by the system for supporting the national HIV program as well. So again, pretty straightforward stuff. And one thing I wanted to sorry, some of my slides are a bit. I'll just skip to the next one. So this, I don't know if you're able to see this clearly, but this is the data that has been defined for completing a case report form. So there are typically sort of two categories of data. There's clinical information, where you basically enter, again, very simplistic data, where you enter the patient's clinical information. You can see the set of questions here, there are about only 4, and then the symptoms. So again, really easy and quick to do. And so this, for example, would be at a health facility where this system has already been deployed, and it's sitting at the outpatient department. So as patients come through, this data is collected mostly. So this is obviously at syndromic level, and then after this, you can then enter a lab order to basically. So again, in the earlier days, this protocol was really dependent on a healthcare worker to determine when a lab order is required or a lab test is required for example, for someone who has a certain combination of symptoms that might be presenting as a potential COVID case. So then the tests are ordered to confirm what the healthcare provider is observing. And these are typically sent to the couple of labs that were identified to run these tests. And the turnaround time earlier was, I think, up to 4 days. Now it's within 24 hours at most. And the data is then received automatically by the EMR system. This is when I mentioned that we provide 2 options for entering the lab data for confirmatory diagnostics. We've put in a couple of alert systems. For example, you can see here, this yellow alert here shows this patient is, or this case is pending their COVID-19 results. So we have a couple of alerts built in, and all this is based on the algorithms received from WHO and domesticated by the Ministry of Health to provide us the rules to use for creating these alerts. Other features that are available in the system, including contacts management. So again, following the protocols, once, for example, a case is determined to be positive, then that triggers contact tracing. Who do they come in contact with? And the system provides the capability for registering a contact. So initially, you just list out the contacts, but then once especially get the results of the index case and they're positive, then you're required to register a case, and then that will start creating the epidemic tree, and also adding a lot more information about the contacts, including their physical movement and their address, and that's what this is all about in terms of registering and following up contacts. Then the system also allows you to create the epidemic tree as well, where you're able to get some nice simple visuals of the spread from the index case. It also allows you to register contacts. Again, there's a whole protocol of how this is done, and healthcare workers have been trained about on how to effectively use this following those guidelines. There's also an extensive follow-up process, again, that the system has been built to support, where you're able to, also connect with the mobile applications, which are being used a lot by the community healthcare workers to follow through with the contacts. And this, of course, can be done either through calling or through physical tracing. Let's see, sort of skipping forward, at the national level in terms of visualizing the data, the ministry engaged an organization that works with, some of you might know this system called ArcGIS, just for visualizing data. And so all the data pours into their database and they're able to run a couple of analytics and visualization. So like this one shows a line list for patients who are quarantined. And this is data that is fed from the Kenya EMR system. I think I spoke about the quarantine again. So the quarantine institutions are also running Kenya EMR as well. So when someone is quarantined, then they also enroll or registered into the system, which is used at that center. And the same process is followed through for finding a quarantine person and following them up. And also through discharge or transfer of that person, depending on how they're faring along. Again, all that is supported by Kenya EMR. You can also run line listings within the system to dig deeper into specific cases based on the questions you have. And the system also allows you to export those data in various formats, of course, the basic one being CSV. It's just a sample line lists of cases, confirmed cases in Kenya EMR. And you can also run a line list of quarantine persons. That's a sample. And this is some of the activities that are ongoing currently. So the ministry is, with support from its partners, currently rolling this out to subnational units. So Kenya politically is run just like the US, where there's a national, state and federal government. And so it's being pushed out to the public health facilities. There's analysis, as I mentioned, if you look at bullet 3, there's analysis of comorbidity data for patients within the data warehouse. And some work going on risk modeling and also hotspot analysis based on the GIS data, and also looking at advancing the case management model within Kenya EMR. Some of the lessons we've learned, I think these are typical well-known lessons. Is leadership is important. So with the rapidly evolving epidemic, we require to be agile, and that's really been helpful, especially coming from OpenMRS, where this is the typical sort of behavior. Also, I think I must state that it was very helpful for, we were able to stand this up very quickly just because of the experience with the HIV program. And I think these lessons have come up very clearly, as Hamish mentioned, some of the challenges that are faced with when Ebola broke out. I think the global community was able to overcome this fairly well just based on the achievement through PEPFAR. We've reused digital public goods as listed by Hamish. And there's ongoing enhancement of this system. So in this last 2 minutes, I just want to mention quickly about some work we're doing cross-border between Kenya and Uganda. Some of you might know this image, but this is, I picked this from the OpenHIE community. So this is OpenHIE sort of architectural framework that shows, these are the patient management system at the bottom here. So if you look at this from the right, this like represents Kenya, this vertical. At the bottom here, you have the patient management systems of health facilities. So where you have Kenya EMR, a distribution of OpenMRS, and Ampath Medical Record System, also a distribution of OpenMRS. Data getting through the Open Health Information Mediator, and then landing in different places at the national level, usually in the HMIS system, which is powered by DHIS2. Now, Kenya and Uganda Ministry of Health have both recognized and are using OpenHIM as the interoperability layer. And so what we did in this project is that we set up OpenHIM to then connect these two countries. So basically data would, so let's say at the border, at the cross-border site, a confirmed COVID-19 or a COVID case who has been seen on the Kenyan side at a health facility that is using Kenya EMR would then, the data would then go through OpenHIM that is run by the Ministry of Health. And then through the data sharing agreement between Kenya and Uganda, that data would end up in the sort of collective OpenHIM that is used by the two countries. And that's, so this person who's transferred from a facility in Kenya, the data would go up this way into OpenHIM. And then from OpenHIM, it would basically, if this person is being transferred to a facility in Uganda, The data would then go through from OpenHIM to their shared health record, and through OpenHIM to the health facility at the bottom. This is theoretically how we set it up, but we actually went ahead and implemented it. Initially, we were doing it for HIV, but now the two ministries are working with them to move this to using for COVID cases. And coincidentally, we got funded by Digital Square to actually do this. And so we're using these previous projects to then implement this OpenHIM COVID digital data exchange solution. So it follows the same logic I've mentioned. At the bottom here, you see Kenya EMR COVID-19 tracking system, and some data could also come through the AMPATH medical record system, both OpenMRS, and go through the same framework I've mentioned. And data right now, data will go to the national HMIS, which is powered by DHIS2, but we're also putting up a Happy Fire server that supports the COVID-19 fire implementation guide. So this work just started. Very exciting. So we're actually building COVID-19 mediators through the mediator framework provided by OpenHIM. And if time allows and we have more funding, we're also planning to invest in developing a fire clinical data warehouse where we can do a lot more with the patient level data. Yeah, and that's it from me. Thank you.
Thank you, Stephen. That was great and really helpful update. Even since the last time I saw this a month or two ago, things are really moving forward well there, I can see. And it's a real tribute to Kenya. The amount of innovation and the amount of really high quality systems being developed and deployed there is quite impressive. And being able to do things like cross-border sharing of data of patients, with COVID-19 or potential risk of COVID-19, it's obviously a very powerful opportunity. We don't have much time left. I had a couple more things I wanted to say very quickly, which I will try and do here. That's not looking like the right one.
So while you're shifting your slides, there is a question from an audience member. So Stephen, you mentioned that a toolkit was created for supporting the use of the EMR out in the community during the COVID-19 period. Do you have any data that supports how the toolkit was used, whether it was used, and how your team made sure the teams on the ground had the support that they needed to use the EMR as you intended it?
I don't have the data with me right now, but I can get that. But basically, what I can say is that I think what really helped a lot, just in terms of the experience we've had, I think it's the fact that there's been a very strong network of HIV digital health solutions, and Kenya EMR is one of the central systems in that ecosystem. So that we're able to leverage and repurpose a lot of that existing infrastructure.
That's excellent. Thank you.
Do you get the one or the two slides here, Ian? Neil?
We're right at if there's.
That's like, you got the one slide, yeah? Okay. So just couple of quick comments before we go. So these are examples where people have used OpenMRS to export data for research projects. Some by our colleague Joe Hogan here in Brown, and also some work we did in Peru with drug-resistant TB data. And this is the IDEA project, which shares data from a number of African countries using OpenMRS. And these are using somewhat ad hoc approaches to extract the data. So the plan is, as Stephen described, to standardize on a more FHIR-based approach to export the data in the ETL process, and then use tools like I2B2 and Odyssey. And so that kind of ties into some really great work done by colleagues in Harvard Medical School and around the world, sharing data from a whole range of different EHR systems and standardizing that data, using I2B2 primarily, but also Odyssey, so that they could then share the outcome data on laboratory results at different points in the hospital care of patients with COVID-19. And so finally, just a quick comment about how do we actually understand what works well with these systems. Don't have time to talk about it today, but this is showing all the OpenMRS sites in in Rwanda. And this is a study which we've been completing recently, looking at a whole range of different aspects of the systems, including the performance, data quality, and usability of OpenMRS systems. We're doing an RCT of clinical impact of decision support on HIV care. and also looking at the cost and cost effectiveness of systems so that we can actually determine what works well and to improve the way we implement and use systems. And so that's all really I had to say. So any other questions before we go?
There's one question on, are there any public wiki links where all OpenMRS and current COVID work modules, etc., are being collated that I could possibly bookmark and track?
And the answer is most definitely yes. So openmrs.org is the website, but we'll add that to Tara's list of the different sites, as well as we also have a demo version of the OpenMRS reference application from Haiti that Ian stood up last year for our medical students, and we've been using that recently for an AMIA meeting. So we can give you access to that to try it out if you're interested as well. And then there are a range of different links around the COVID work, but we can also follow up in detail if you want to know more about that.
All right, we are right at time. Thank you both, Professor Fraser and Stephen, for your very insightful presentation. I think that there's a lot that we can learn from the open source community, and OpenMRS definitely leads the way. And so it was really great to see how it's been used in the current pandemic. So thank you very much.
Thank you, Neil.
Thank you.